Okay, so for the abdomen, we are going to be using a 14 by 17, which I already put in here, lengthwise. And then we are going to have a right marker for the upright abdomen. I like it to be in this upper corner because it won't be in the abdominal anatomy that we're looking at. It'll be in the lower portion of the lungs if it's in anatomy. And then on the supine, we should put it in the bottom corner of the image receptor because that's going to have it in the soft tissue area of like the hips and stuff. Versus if it's in the top, it could be over a gas bubble or something like that. So still trying to have it out of the way. We are not going to collimate for any of the abdomens. Leave it open the 17 top to bottom and 14 side to side. So I'm going to go ahead and lower this down. For our centering for upright, we're going to find our patient's crest and go 2 inches above. Poke on you. There it is. Go right about there. And then bring this down behind you. And then come to the midline a little bit. For the upright abdomen, if your patient is tall enough, we can put the rolling shield in front. Don't know if Rain is tall enough or not. I don't have light field on here, so we'll leave it there. It's not superimposing. And then arms just at the sides is fine. We don't need to do anything super crazy. And can't tell if I'm in the middle of you or not. No, we need to come here this way, right there. Okay, and then our breathing instructions is take a deep breath in, blow it out, and hold it out so we get that diaphragm up, and we take our exposure, okay? So this is the upright. So with the book, it says 2 inches above the crest, and then it also says the top of our IR should be at about the armpit level, which if we look at our light field compared to our armpit, we are about there. If you have somebody who's 6'4" and has a really long torso, you're going to want to go with top of the light field being at the armpit over the crest centering, okay? Because we want to make sure we have that diaphragm in that picture, and then worst case scenario, if we need to do a lower image, we can. But if you have someone who's really tall, we want to come up higher to the armpit first so we make sure we're not clipping diaphragm. Make sense? All right, now I'm gonna have my patient lay down for me. We're going to rotate the camera, just fix it. So we can see the entirety of it, okay. And now, since we're using the table bucky, we're going to go to our 40-inch line on the tower of the tube. And then we're gonna bring our table up to the blue light, so when it stops. Another important thing when we're doing supine abdomen, we want to make sure that we come either to the head or the foot of the bed and make sure that your patient is straight. So Raina needs to move her hips to the left and your feet. There you go. So now she's in a straight line on the table so that nothing's wonky. We don't want our patient getting a false scoliosis diagnosis. So, and then for this one, we are centering for the KUB supine. We're centering at the level of the crest. Okay, so I'm going to poke on my patient, find her crest, which is right there, and we're going to come up into the midline, right about there. And remember, we don't open our light field any bigger than the 14 by 17. We trust our beam divergence. However, I'm not quite at 17. There we go. So line up our image receptor, which was already in here. And I have a broken table. Okay. I have a right marker down here in the bottom corner of the IR, right? Because that means that it's not going to be in my anatomy. Make sure that the hands are away from the body just a little bit so they don't end up underneath. And then for this one, we're actually going to use this little baby shield on the patient's chest to kind of shield the chest and thyroid. So we'll put that here. And then I'm centered good, I'm lined up, and same breathing instructions, deep breath in, blow it out, and hold it out, okay? I do like to tell my patients to take that first breath in because I feel like when I've told patients to just blow their air out and hold it out, they're like, suddenly they need to breathe within 3 seconds. So if they've taken a breath in first before they blow it out, they feel like they can hold it out for a little bit longer. Okay? So then from here, let's do our decube views. So for our abdomen, what do we always do for the lateral decube? Left lateral, because that puts our right side up and allows any air to be trapped under the liver if there's free air. So always a left lateral decube. But we're gonna start with our dorsal decube instead. So dorsal decube means my patient stays flat on her back, and we have our patient put her arms up over her head, and this will show us an umbilical hernia if there is one, as well as an aortic aneurysm or calcification of the aorta. Okay, so I'm going with my same image receptor orientation. Put this under my patient here, and then scooch all the way to the side for me. Scooch, scooch, there you go. Perfect, and then I'm gonna bring you this direction. I measured it yesterday. It was a 44-inch SID with the tube to here. So, which I guess technically I could probably move the tabletop to get an exact 40 if I was not worried about it. I think 44 is okay though. Okay, so now I need to change my collimation to be open more this direction and close this direction. Sorry if I blinded you, Taylor.
Caught her by surprise.
Okay, so I'm gonna poke on my patient's side. For the dorsal decube, we're still going at the level of the crest, okay? So I'm gonna poke on you again, come a little lower. I'm gonna reach over you here. Actually, we're good there. Okay, so the big thing here is making sure that you have light field coming above the soft tissue of the abdomen, because if we're looking for an umbilical hernia, that's where it's gonna be, is coming out of the belly button, right? That's what an umbilical hernia is, means that bowel is herniated out of the belly button. So make sure you have light field coming above, and then we mark the side against the image receptor. So in this case, this would be right. That doesn't really matter with the abdomen. If we go by the standard, we could do it as a left, but it doesn't really make a difference for abdominal stuff, okay? For the dorsal decube when she's flat on her back. So same breathing instructions, breath in, blow it out, hold it out, and that is our dorsal decube, which I guess maybe I could bring this to the side to show the picture. Okay, so that's what our dorsal decube looks like there. Okay, so then for the left lateral decube, it doesn't matter if it's done AP or PA. For your patient, it can be more comfortable for them to lay against the image receptor so they can kind of feel more secure, or like they're not holding themselves up as much, but it doesn't matter. So in this instance, I'm gonna take that shield from you, and I'm gonna have you lay on your left side. So you're gonna face me. Don't lose any of your oodles of things there. All right, and then her arms are gonna come up. So with this, remember our patient needs to lay here for how long before we take the image? 10 to 20 minutes. So at very minimum, 5 minutes, but preferably they're there for 10 to 20, okay? And with that, they don't have to have their arms all up above their head that whole time and stuff. They can be comfortable laying on this left side for that 10 to 20 minutes, and then when you reach, you know, the 15-minute mark, you can come get everything set up and ready for your picture, okay? So in this one, we're centering the 2 inches above the crest because we are mimicking an upright abdomen, okay? We're looking for that air fluid, so we still need to see that diaphragm area, so we're gonna center 2 inches above, okay? So I'll poke on you, which with all your shifting about, you almost got there anyway. All right, so good. And then I'm just going to push this detector a little more superior. And centered good. My light field is good. And then arms are up, and we would use a right marker because the right side is up, and same breathing instructions. Breath in, blow it out, hold it out. Okay? So this one is like that and pretty much the same. So I will go ahead and